Thanks very much. It's strange and also at the same time really lovely to see so many people attending. This is the first live meeting I've actually, I think, attended in 2 years, so it's a real treat and hopefully won't be the last. So I was asked to talk about PCSK9 and have we reached the limits of lipid lowering, and these are a list of my disclosures. And what I thought I would do is really separate that question into 3 parts and try and answer each of those that I think probably is a more appropriate set of questions. So what are the questions? So the first one is obviously, have we reached the limits of lipid lowering? And we can think about that at a population level, and we can think about that for individual patients. And then the second question, I think, is actually really interesting, which is, have we reached the limits of PCSK9 targeted therapies? And then finally, have we reached the limits of cardiovascular outcomes? So 3 different sets of questions. So let's start with this. As you know, in our country, unfortunately, our guidelines for, if you like, lipid modification date back to 2014. They're woefully out of date. They still talk about statins and more or less statins only. And so I thought I would show you this. This is probably the best set of contemporary guidelines. And basically, we don't separate primary and secondary prevention necessarily. Risk is risk. And if you have a high enough 10-year risk of cardiovascular events, your LDL cholesterol goals are the same, in essence. A second part of this is the fact that we should be trying to achieve a 50% reduction in LDL cholesterol. Now, why is that? Well, that's really to get us to try and use optimal doses of statins, not 10 milligrams of simvastatin, pravastatin, etc., but the higher doses of atorvastatin, rosuvastatin, essentially. And what we should be able to achieve on average is somewhere approaching 50% lowering. So if you do the maths, and on the right-hand side is this really useful table, essentially, if I'm achieving a 50% reduction in LDL, and my goal is a 1.4 millimole target, for example, in people with established cardiovascular disease, it's not rocket science to guess that basically if you started above 2.8, it's unlikely we're going to be able to achieve that with statin-based monotherapy. Now, we can get some insights into how we're practicing. We're very different from the hypertension field. Essentially, in Europe, 84% of prescribing is statin-based monotherapy. And you could look at this, and the usual thing that we've seen in all these Eurospire surveys is, well, we should be using more statins. That was what we used to say. Then we moved to, we should be using more high-intensity statins. Well, when you go from using a moderate-intensity statin, atorva 20, to atorva 40, you only get another 6% lowering of LDL cholesterol. So if you do the maths, and these are the old ESC goals, so that the target was 1.8, and then we moved to 1.4, you can see that goal attainment, i.e. getting below 1.8, increases with the use of the intensity of statins in the background. You do a little bit better when you start to use combination therapy, and a little bit better when you use more potent combination therapeutic agents. But combination therapy is only used in 10% of Europe, at least in this registry, and fairly similar in the Santorini study. In Europe, in the UK, it's about 3%. When we look at the shaded boxes, we move to 1.4. Even if we maximize the use of statins, or if we add in ezetimibe, about 45% to 50% of our patients are going to achieve goal. So we're going to have to think about a third oral drug or something that targets PCSK9. Now, you can look at the population distribution of LDL cholesterol, and essentially, these are people in Sweetheart with a myocardial infarction. And this is their LDL distribution at admission, and that's the general target. Now, if we give them statins and a variable range of doses, we move this population distribution curve to the left. We don't get everybody below 1.4. So they've simulated what optimizing statins would do, and that's that 6% rule. We only shift it a little bit more to the left, the peak. So it's not quite there. If we add in ezetimibe, more patients are to the left of that 1.4 line, but a substantial proportion are to the right. And this is the simulation for what would happen if we were to add in a PCSK9 inhibitor in this patient population. So if you basically now ask the question, have we reached the limits of LDL lowering? At a population level, nowhere near it, and we're not going to get there without using combination therapy. At an individual level, yes, we could probably get most of our patients to those goals relatively easily, with the exception of homozygous FH. By and large, these are people with little or no LDL receptor function, so you have to think about non-LDL receptor mediated clearance, whether that's apheresis, angioPTL3, reducing production with drugs like limipid, for example. So for the general population, we can get there. Now, if we change the question to why PCSK9, so let's go back to a bit of biology. So essentially, when we use statins, and there are newer agents as well that we can add in the same pathway, like bempedoic acid, basically the principle is the same. We reduce the production of cholesterol within the hepatocyte principally. Now, when you do that, you upregulate the production of the steroid binding response element. And as a result of that, what you do is increase the transcription of the gene for the LDL receptor. So you make more LDL receptors. And that's really what results in the drop in circulating cholesterol levels. But when this binds to the LDL particles or ApoB containing lipoproteins and internalized, you get the removal of the particle, and the LDL receptor has to be recycled back to the cell surface. And that would be great. Except when you drop intracellular cholesterol, what you do is the SREBP element also increases the production of PCSK9. 80% of what is in blood comes from the liver. There are other sources as well, such as the kidney, for example, but 80% is in blood. And what PCSK9 does is when it binds to the LDL receptor and there's a cleft, and that is internalized, the LDL receptor cannot get recycled. It's destroyed. So that is part of the reason when you double the dose of statins, you actually don't continue to see a doubling of effect. So it makes sense that if I can make more LDL receptors and I could keep them alive longer by targeting anything along this particular pathway, I'm probably going to have the most efficient process we currently have to reducing circulating cholesterol levels. Now, the way that we've targeted this is with monoclonals. So if you like, basically what we're doing is using a bucket to catch PCSK9, most of which is coming from the liver. Instead of using a bucket which will get full and we need to replace, why don't we just stop the tap from leaking? And that's what RNA-based therapies do by targeting translation, so the link between the gene and the protein, and I'll talk about that in a second. So let's sort of look at the kinetics and the relationship between free PCSK9 and cholesterol levels. So these are kinetic studies with single injections of monoclonal antibodies, 21 milligrams, 70 milligrams, and 140 milligrams of evolocumab every 2 weeks. So if I use a small amount of drug, I get a big drop, 60%, in free PCSK9. But remember, the liver is continuing to produce PCSK9, so it'll be overwhelmed. The amount of drug I've got available will be overwhelmed. So this will go back up. And this is the corollary, if you like, the reduction in LDL cholesterol, and you get these large peaks and troughs. So if I have more drug available, again, every 2 weeks, I bind more PCSK9. There's less to bind to the LDL receptor and stop it from being destroyed. But at this dose, I'm probably going to have to go to a dosing interval weekly if I want to basically maintain a steady reduction in LDL of about 50%. If I use more drug, I can basically space out the dosing interval. I can go to 2 weeks. And now, basically, I'm able to mop up everything that's coming from the liver, mostly. And so I get this profile. This is why you can use 420, 3 times the dose, monthly. There's just a lot more drug available. So instead of that, we can switch the tap off, and there are 2 approaches. You can either target translation in the nucleus, and this is an antisense-based approach. So it's a single strand of RNA, and it works inside the nucleus. But again, through Watson-Crick hybridization, you are binding to a complementary sequence of messenger RNA, your target of interest. And it's broken down catalytically by an enzyme called RNase H. This occurs inside the nucleus. So this is being tested at the moment for LPA lowering, but it's a monthly injection. On the other hand, nature's given us an intrinsic process for switching off proteins, the RNA-induced silencing complex, small interference RNA. So naturally, this complex sitting in the cytoplasm recognizes naturally occurring sequences of double-stranded RNA. The antisense strand, much like on the left-hand side, is retained, and it can break down multiple transcripts. If we piggyback onto this and create a double-stranded RNA complex, and we can get it into the cytoplasm, in particular into the hepatocyte, we've got a system whereby this strand of drug, the antisense strand, is protected from breakdown by nucleases, and that could give us potentially a long duration of action. Now, the next issue is how on earth do I get it into the liver? So if you think about drug discovery and drug development, we tend to often choose doses where, we're kind of happy to manage safety and efficacy. And one of the issues with early approaches was we had to inject a lot of drug, and so you got a lot of local injection site reactions. These were in the days of mipomersen targeting ApoB. The discovery that the liver expresses a receptor called the acyl-glycoprotein receptor has basically revolutionized all RNA-based therapies, and essentially recognized that this basically binds to a sugar-like residue called N-acetylgalactosamine, and the function of this is recognize senescent cells and remove them from the circulation. We can tag any drug with this complex. So within a short period of time, we can put a small amount of drug subcutaneously. Within 4 hours or so, it's in the liver for any target. And what we then did was to test this. So this was the phase 1 data, looked good. We had no idea how long this was going to act for. And so this was the phase 2 dose ranging study. We picked 3 doses of inclisiran, and on a background of statins and ezetimibe, maximum tolerated statins, single injection, 3 doses, dose escalation study here, and placebo. But look at the peak effect. So we've already got within 15 days, 40% reduction, peak effect somewhere between 30 and 60 days, and a steady decline towards baseline at about 2 to 4% per month. But what's more impressive, and that will relate to the next point, or the third point later on, is the area under the curve, what I call the time average reduction. Because if you think about a MAB or a statin, giving a single dose and measuring cholesterol levels monthly, it's not going to look like this. So that's really how we should start to think about chronic diseases and this whole concept of cumulative exposure. With the second dose, when you do this, you always use a slightly lower dose, but more frequently. So we've modeled this data, and we chose 100, 200, 300. So with a second dose now at day 90, you get a little bit more LDL reduction. Your peak effect is about 55%. And what you get in return is this longer, steady duration of action. So you've kind of saturated the risk complex. And it means you could potentially get thereafter to a 6-monthly dosing interval. So the area under the curve with 2 injections is about 50% lowering of LDL cholesterol. So when we took this into the phase 3 studies, Orion 9, 10, and 11, what we did was dose on day 1, day 90, and 6 monthly thereafter. And we had 2 co-primary endpoints. The peak effect at month 17, so day 5, 10, and most importantly, the area under the curve, if you will, during this period between day 90 and day 540. Because after year 1, we should be able to go to twice-a-year dosing. And that's really what we should be interested in terms of our patients. So what we basically showed was actually you could, instead of having that bucket-like approach, you could actually switch the tap off. This is Orion 10 in ASCVD, Orion 11 in ASCVD in primary prevention patients. 6 monthly injections shut off the hepatic PCSK9 tap. So you can actually get an 80% reduction in circulating levels. There's still some PCSK9 from elsewhere. And that translates into peak and trough profiles that look like this. So you can achieve, on average, about a 50% reduction in LDL cholesterol. Now, if you look at heterozygous FH, we found nowhere near the total population globally, a condition occurring in 1 in 311 individuals globally, where essentially the commonest mutation, the commonest abnormality, is in the LDL receptor. But that basically means there's one normal gene. You can upregulate that with statins in the background, but you're effectively working on half your cylinder, so you're not going to be able to shift cholesterol as effectively, so your LDL levels are about really quite high, so they're over 4. Now, by switching that tap off, you can make those LDL receptors that you're now ramping up survive longer. So very simply, you can get almost another 50% lowering on top of statins. So again, combination therapy. So that's great. We've got now 2 approaches. Inclisiran's now approved in the UK and many other parts of the world. And some of you that followed the AHA will know that there was some data presented in a phase 1 study of a small molecule. So to really look at all the potential targets for PCSK9, we need to look at this. So essentially, however they're working, they will effectively result in increasing the cell survival of the LDL receptor. So you can target it at multiple pathways or multiple points. The monoclonals are every 2 weeks. So this is an approach called adnectins, and we can basically use these protein molecules which allow a once-a-month injection regimen. They give you about 60% lowering or so of PCSK9. You have these small molecules, and what they do is they'll bind to the cleft and stop PCSK9, so it's competitive. But that means that you're going to have to dose it regularly every single day. So they can give you the same benefit, but there's a greater burden on the patient. We might have vaccines in the future. That's really been tested in animal models so far. Whether they're durable, how long they last, we don't know. And you can think about, for example, some of the vaccine issues we've got at the moment. We've got inclisiran, which basically is working in the liver, in the cytoplasm, to target this side of the process. You'll also see data, certainly, on an oral antisense oligonucleotide. So a first oral approach that is an antisense approach, been taken up, gets into the nucleus and can target PCSK9 messenger RNA. There's also an injectable approach as well that will be starting. And potentially in the future, base editing for using CRISPR-Cas9 for the PCSK9 gene. So effectively, you're creating a knockout. So all of those will effectively reduce the amount of free PCSK9 or its effect on the LDL receptor and enhance its survival. So have we reached the limits of targeting PCSK9? Nowhere near it. There are a number of different approaches, and the only real difference is likely to be cost, convenience, potentially safety with things like gene editing. So what about outcomes? Probably the most important thing of all. So we have to change our concept in terms of how we approach prevention. This is data from Sweetheart, and this is basically a registry of myocardial infarction. These are all the patients coming into hospital, and these are the absolute reductions in LDL cholesterol, and outcomes are shown here. What I want to draw your attention is to this. Look at the number of people, 3/4 of patients that came in with an MI. Very few were on a statin the day, the month, the year before they came in. So that is a failure of how we approach risk assessment and primary prevention. That's really got to change if we want to dent cardiovascular disease in the future. And to really look at that in a bit more detail, we need to think about all of these things in terms of cumulative exposure and benefits. So this is the totality of the global data for LDL lowering or differences via 3 lines of evidence. Randomized controlled trials of about 5 years duration, and essentially the average age of your patients is going to be about 60. Mostly statins, but other things as well could map on there. Observational data, 12 years of follow-up, the average age is about 40. Then Mendelian randomization genetic data, so you look at LDL differences over about 50 years. And what you can see is that if you look at absolute differences in LDL and relative risk reduction, basically the lower your LDL, the lower your relative risk. So what's different between the 3 slopes? It's just time. So in theory, if you were able to better assess risk early, you could change, you could course correct by 0.3 millimoles, but you're going to have to maintain that for a lot longer, about 50 years, to get the same benefit as a 1 millimole reduction starting, for example, later in life. So you can explore that in a little bit more detail. Now, fortunately, nature really doesn't care about the order of the guidelines and the cost of the therapies. What nature really asks you is, well, are there any meaningful differences between a statin-like approach, ezetimibe, or a PCSK9-directed therapy? So when you standardize for LDL differences, the benefit is exactly the same. So whether there are benefits on CRP, inflammation, LP-little a, at a population level, the vast majority, when you achieve LDL lowering through these approaches, it's all explained by LDL. So that's really, or ApoB for that matter. So that helps us potentially in the future. I want to show you these data. So let me walk you through this. Not many people would have looked at the data in this way. So one of the things that we've done over time is looked at between person variation and percentage reduction. This is a waterfall plot of time. So what these are showing you are individual patients that still have more than 20% reduction in LDL from baseline. So these individuals here still, after a single injection, have more than 20% reduction of LDL from baseline. And these are censored at the point where they've returned below that level. So with a second dose of inclisiran on day 90, that's how many people are still reacting or responding. So we can, in the future, if we basically look at primary prevention, think about an annualized reduction in LDL of about 36% at a population level on average with a single injection of that drug. 2 injections, and for comparison, is a little bit more. But this is some data that we presented earlier on this year. Let me walk you through this. So you can start lowering LDL by 36% at different ages. And this is basically what the event rates look like. So you could lower LDL by 36% age 30. And this is lifelong reduction, this is age 30, and essentially at different decades. And this is somebody that's, or a group of individuals that are untreated. What's the difference? The difference is the timing of this, and that's men and that's women. So essentially, you could have a scenario where, based on the age of the individual, the trajectory of the individual, you could personalize the amount of LDL reduction needed. So later in life, you could think about a 50% reduction in LDL. If you started earlier, you might think about at age 40, for example, you could think about a 36% reduction in LDL. And by comparison, this is untreated, and these are people with lifelong reductions, men and women. So I think, really, what we might see in the future, PCSK9 directed therapies, potentially all the differences between siRNAs in the future, vaccination, potentially gene editing, compared to other approaches that we've got for LDL lowering, is really overcoming some of the issues we've got with chronic therapies, which is adherence. And that will achieve a better area under the curve, and over 52 years, particularly if you can think about prevention early, you should achieve much bigger population health and population benefits. And that's work that many of us are interested in. So in summary, for the last question, have we reached the limits of CVD risk reduction? The answer is no, we're really just getting started. And particularly if we start early, we will be able to change the course of a lot of these outcomes. So thank you for listening.